All right, take it away, Rick.
Hey, everybody. Welcome. Thanks for joining me today. We did this talk last year, and we've updated a few things on the slides just to give you a few more scenarios and hopefully have time for you to answer or ask questions. What's kind of a coincidence, interesting today, is I just finished a 2.5 hour call with the PT Board of California. I do these calls. We try to do them quarterly with CPTA. And so I had an opportunity to talk to the head of enforcement and to Jason Kaiser, who's the executive director, specifically about direct access issues. And I'll fill you in a little bit more on that later. But so what I wanted to talk to you today about is just to let you know where direct access is, that we're not one of the 20 states that has unrestricted direct access. We hope to get there soon, and with some upcoming revisions to the PT Practice Act, probably next year, the year after, that will be included. But until then, we're one of the states that has some different form of direct access, which just limits the duration of time that you can see a patient without either without referral, without diagnosis. So we'll get there, but we're actually one of the better states in terms of allowing for direct access. So everything kind of comes down to whether or not you have a diagnosis in direct access. The diagnosis, or having a diagnosis, and when I say diagnosis, I'm going to make that synonymous with using the term verifiable diagnosis, not something that you diagnose, but something that is the patient has a diagnosis for somebody who's legally able to diagnose in California. If you have a diagnosis and you're treating that patient for that diagnosis, and you feel comfortable about that, then it is not direct access. So the use of the diagnosis is really kind of the key to what we're talking about here. And the law says that anytime you evaluate a patient, regardless of having a diagnosis, not having a diagnosis, that if you uncover symptoms or you have a patient that you believe has an underlying condition that is not related to what you're treating, or even related to what you're treating, but requires a more extensive evaluation by a physician or more diagnostic workup, that you are obligated by law to refer that patient on to the appropriate provider who can then do that follow-up. So you can't kind of hide under the fact that we have a direct access ability here, and we can just kind of put other things aside. So, always cluing into your red flags and other things that may indicate the patient has an underlying condition that goes beyond the scope of our practice. So we are obligated to refer the patient to a physician, to an osteopathic physician, to a podiatrist, a dentist, or a chiropractor. Those individuals are in the statute, in the law, that we can refer to. So when a patient comes in that does not have a referral diagnosis or that you're treating for pre-existing condition, it's basically a new new injury, an injury that you haven't seen them for before. You have 12 visits or 45 days, and those are calendar days, to see that patient before they then have to then see a physician. And what's required in law is at the end of that 12 visits or 45 days, or before the 12 visits and 45-day limit, that individual has a consult with the physician, and then that physician will sign the plan of care that you send over. Now, if the physician sends over a diagnosis instead of the signed plan of care, then you're good. Then you're no longer in direct access. If they sign the plan of care, then that counts as exempting you from further requirements under direct access. So you basically are seeing the patient under the care of a physician. So what happened this last legislative session is that a requirement was that patient had to have an in-face or face-to-face visit with the physician at the end of that 12 visits or 45 days. with the pandemic, and that we were able to get the Practice Act updated to say that that could be a video conference. So it's at the physician's discretion if they have to do it in person or for video. Kind of a minor technicality, but it is kind of a step in the right direction. We are required to notice the patient, and this notice is very important for us. This is kind of your protection that you are following the law. So the patient has to receive the notice, and that should be signed and scanned into the patient's record. So there are areas of confusion. What I'm gonna do is I'm gonna go through just some general areas here, and then we're gonna get into some specific case examples that to kind of illustrate some of these areas of confusion. So a patient who has an existing and verifiable diagnosis does not have to be treated under the direct access rules. So a verifiable diagnosis is something that is important. And the way that we usually verify a diagnosis is that either the patient has been seen by a physician before, and and they can identify that physician, and you feel confident that that physician provided the diagnosis, then you are exempt from the direct access laws. If you have a patient that comes in, and let's say they provide you with a radiology report, and that radiology report has a diagnosis on it for a condition that you're treating, then that's a verifiable diagnosis, and that radiologist's name should be listed to verify the diagnosis. But if it's not a condition you're treating, then obviously that doesn't count. Note that payers set their own requirements, and here's where we kind of get into a lot of areas of confusion. We'll go into more detail in a little bit here, but a payer can require a referral or a diagnosis by a physician in order to get paid. And I have a list of some of the payers that require that and some that don't. And just so you know, we're moving in the right direction with payers to get them to remove that requirement. California law in our direct access law states that it does not mandate that the payers have to accept or pay for a patient being seen on direct access. That was part of one of the things we had to give up when we got the direct access laws, that we couldn't mandate that the payers had to pay for direct access. So that is not in California law. So payers can set their own rules. And just to say, anytime you have a referral or a diagnosis that's written down, it helps establish the medical necessity of your care. So even though you may not need it for direct access, it's always nice to have that. Anytime we try to defend what we're doing, it's nice to have that in place. But again, for true direct access, it's not required. And so a patient who returns to care following your discharge without a referral for the same condition, it can be considered direct access if you are treating the patient for the same condition. But if you have a diagnosis, if it's a previously diagnosed condition that you're seeing them for again, it is not direct access that second time around, because they have a diagnosis. So if at any point the patient comes in with that diagnosis, they are exempt from following the rules under direct access, and you can see them as long as you know where that diagnosis came from. So insurance requirements in California right now, these payers right now do not require us to have a referral or a prescription. And I put referral prescription, and those of you who know me, I don't like using the word prescription because it's very rare that we actually get a prescription from a physician that tells us exactly what we are going to do, that prescribes the actual interventions you're going to do. It's a treat for shoulder condition, or they just give you a frequency and a diagnosis, but very rarely do they state that you need to do mobilization of shoulder followed by ice and electrical stim. They don't usually write all that in a referral. So we tend to want to use a referral because we're the ones that basically establish the plan of care. But these payers, Aetna, Blue Shield, and United Healthcare Optum, are ones that have in their policies that they don't require that referral to get paid. So we know that as from our claims processing. Anthem is on a case-by-case basis. And the reason I say that is Anthem has different policies based upon the plan. And the way plans are developed is a lot of times they're developed with a large employer group that insures their employees. And when the plan is developed, they design in the plan that referrals aren't required or they are required. A lot of times if it's silent on it, it means that they usually require the referral. So we still have that with Anthem, and it's based upon the phone call and during the verification process of whether or not they require the referral. Cigna and ASH is in the process of changing their policies. Right now, ASH has been requiring us to get a referral after 12 visits, but in some of their plans, they're asking for it right away. I was on a national call with Cigna a couple of weeks ago, and they have decided that they are lifting the requirement for a referral. However, for that to filter down into the processing side of it, into their system, and for ASH to take a hold of that and apply it, is probably going to take some time. So kind of stay tuned on the ASH Cigna issue. Our managed Medi-Cal plans require referral. The Community Healthcare Group and Molina, they require referral. We're going to talk about Medicare separately here in a minute. So in Raintree, this is where you put in on Raintree, which says prescribing MD when you're dealing with a direct access patient. You want to make sure that if it is true direct access, that you are indicating it into Raintree. So let's talk about a few different scenarios here that may answer a lot of your questions and help some of the confusion, and then we'll open it up for a Q&A. So you have a patient who's been seen for low back pain with a referral from a physician, and during the course of care, the patient develops symptoms in the cervical spine. Can you treat the cervical spine? And is it considered a separate condition and therefore initiates applying direct access rules? So the answer is, if your initial evaluation included assessment of the cervical spine and you had your plan of care signed by a physician, then it would not be considered direct access for the cervical spine. And you can go ahead and treat them as if you were treating the low back that they came in for. If you initiate a new medical record and the documented distinct onset of symptoms not previously addressed, it would be considered a separate condition with a new 12 visit or 45-day limit to that condition. So the way that this is evaluated, each condition that the patient has would require that condition to be evaluated as whether it's direct access or not direct access. So you have a patient with low back pain that comes in and says that my neck is hurting me, and the referral was for the low back with the diagnosis for the low back. The neck could be treated, but it would be under direct access. So you have to actually at that point in time notice the patient with the 12 visits or 45 days for their neck condition that you don't have the referral for them. Now, if you go ahead and do your plan of care and send it off to the physician, they sign it, then they're outside of direct access. Or if you call the physician's office and say, hey, listen, Mrs. Jones is also having some neck pain. Can you send over a referral with a diagnosis on it? Then it's not direct access. But this can get confusing if you're treating two different body parts. But understand each body part from the standpoint of law is that they are treated separately. It's almost if it's separate patients. So here's another scenario. A previously diagnosed patient returns to your clinic with similar complaints and would like to be treated without visiting her physician. Can you treat the patient as direct access? So think about that a second. They are previously diagnosed. They return with similar complaints, and you want to know if you can go ahead and treat them without them visiting the doctor. Does that consider direct access? The answer is it would not be direct access if you determine through your evaluation that the patient is actually presenting with just a reoccurrence of the previous symptoms with the same body part, and that you feel comfortable that the diagnosis you treated them under before applies to this episode of care. That's not direct access. It means that patient, you don't have the 12 visits and 45 days. Now, you may be seeing them directly. They may be self-referring themselves, but they were self-referring themselves for a reoccurrence of a condition you previously treated them for with a diagnosis on file. That means you can treat them. The holdup is whether or not their insurance will require a referral for that. Again, separating out the payment side of it from the true legal side from direct access. We can't, sometimes we just get mixed up on that in our heads as to, oh yeah, the patient's coming back to me, it's direct access. Well, they're coming back to the same condition. You don't have to follow 12 visits or 45 days and notice the patient, but you may need the referral based upon the payer requirement. So when initial authorization, when you call up to verify benefits, you're going to find out whether or not that referral is required. If they're presenting without a referral, a prescription, you must document that specifically as being a reoccurrence of an existing condition with a previously diagnosed condition. And the law also states that with the patient's approval, you should be sending your evaluation plan of care to their physician if they have one on file. It's something you should always be asking the patient if it's a direct access. So do you have a physician of record? Do you have a primary care? Do you have an orthopedic surgeon that you've been seeing for, for maybe the same condition or other conditions? And you would like me to send this information to your physician. And think about it from a marketing standpoint, because it's great that you can actually, inform the physician that you're caring for their patient and that you're referring them back to them to create that relationship with the doctor. So under the scenario where the patient's returning with the same condition, you're not under the 12 visit and 45-day limit because you have the diagnosis. But if the patient presented with the same general condition, but your evaluation does not indicate that the cause or etiology is the same as the previous diagnosis, then that is direct access. And you would be required to notice the patient and only treat them for up to 12 visits or 45 days. And again, if they have a physician on file, send the report to the physician. In that case, it would behoove you to actually ask to have your plan of care signed. And technically, the patient needs to go back to see the doctor or do a video conferencing, but if it's at the physician's discretion, if they go ahead and sign that plan of care, then you're good. You're good to go beyond the 12 visits in 45 days. Third scenario, the patient presents to you with bilateral hip pain and indicates that they were diagnosed many years ago with rheumatoid arthritis. Can you treat them? And would this be considered direct access? So they come to you with bilateral hip pain. It says, oh, yeah, I have RA. Can you treat them? Yes, you could. You can treat them under direct access. But if your evaluation reveals that this patient is really having a possible flare-up of their RA, but they haven't seen the rheumatologist in years, then it kind of falls back to what I said in that first slide, is that you really should be sending this patient back to their physician before continuing care, because you're not sure, if they're having a flare up of the RA or something else is going on, and this hip pain is a new symptom for them. You could treat them under direct access, but knowing that they have a condition that may need some other interventions, you should refer them back to the physician. But if you're confident that the symptoms are related to RA and you feel that that is a viable diagnosis for you to treat them under, then you don't have to follow the direct access rules. But you have to know where the source of that rheumatoid arthritis diagnosis came from. You should have it on file as to which physician that was and where that came from. So if you determine that the probable cause is probably not the RA and does not require immediate physician intervention, then you can treat them for direct access. You think of something going on with soft tissue or something else, you can then treat them for the 12 visits in 45 days. But again, that would then be direct access, because you're not really treating them for the RA condition, and you'll need a new diagnosis or assigned plan of care after the 12 visits or 45 days. So this one gets a little bit more confusing for you when we go back to it when we do the Q&A. Scenario number 4, a patient presents with a referral and goes past the original duration and frequency listed on the referral. So you get a referral for 3 times a week for 4 weeks. you finish that up and you don't have another referral on file. There's been some confusion with this scenario saying, oh, okay, then the patient becomes direct access if I don't have another referral. No. Who determines the frequency and duration? And if the patient requires care beyond the initial frequency duration, is a subsequent referral required? So no, nothing in law requires that a referral indicates frequency and duration. That we use that for reimbursement, for payment. If the payer requires that, then we need it. But if the patient is just continuing on their care and their the initial referral is all that's really needed for payment, you don't need another referral to continue to see that patient legally under law, because the initial referral had the diagnosis on it. Again, once you have a diagnosis, it is not considered direct access. So a patient does not become direct access or under your care with a diagnosis. So in this situation, maybe the patient turns into a self-pay patient. You're not worried about the insurance. Or you may find out, you know what, I got to get that referral because the insurance is requiring it. So this one kind of, stumps you a little bit because of the fact that it's really a payer requirement. It's not a legal requirement if that referral or the initial frequency and duration expires. There's nothing in law that says you need to have a physician indicate frequency and duration. But one of the things I want to say about this is that when a physician writes down a frequency and duration, they're asking you to see the patient for that frequency and duration. That's something we should be honoring. If we want to change from that, that should be communicated with the physician, especially if you're dealing with a post-op where you're following protocols and things. You don't want to just arbitrarily change that. That if the patient goes back to the physician and says, oh no, they only saw me once a week instead of 3 times a week. The physician goes, that's not my protocol. And you should be following that. If you don't, you need to communicate that with the physician and come up with a new plan. But that's not a legal requirement. That's a patient management issue. That's, proper communication with the referral source on their plan of care. Okay. We can go back to any of these when I'm done the last one here. So a Kaiser patient comes in as a self-pay without a referral. Can you treat them as direct access? Can you continue to see them beyond 12 visits or 45 days if they continue as self-pay? That's an interesting scenario. Kaiser patient comes to us because maybe they like our care. They want to pay out of pocket because they may not be getting access to care that they need at Kaiser, or they just walk in, but they happen to have Kaiser insurance. So you can treat them as direct access. If they have a verifiable diagnosis, again, then it's not direct access. So you say, wait a minute, they're Kaiser. I'm not going to really be able to call up their doctor and get a referral. Kaiser doctor is not going to give that to me. The patient says, well, yeah, I have a doctor there, but I want to come to you. Can the patient obtain a medical record that has a diagnosis on it? Patients have access to their own medical records. So if they're seen by a doctor and the doctor at Kaiser diagnosed them and you're treating them for that condition, the patient can request a copy of their medical record, maybe radiology report, that could be placed as the diagnosis, and you can treat them beyond the 12 visits of 45 days. If they don't obtain that, and let's just say they give you a verbal diagnosis and you have no way of verifying that, the recommendation is don't take the chance of seeing that patient beyond the 12 visits of 45 days. They should be able to get that verifiable diagnosis for you. And even in that case, it's not a bad idea to send your plan of care and everything to the Kaiser physician. You're not doing anything wrong. You're not, violating any laws. You're just letting the Kaiser doctors know that you're treating the patient. So just note that a verifiable diagnosis can come from different sources. If it's just coming from the patient's recollection of what the doctor said to them, I don't consider that a verifiable diagnosis. So if you don't have that, then you're under the direct access rules of 12 visits or 45 days. And if you can't get a diagnosis, you really should terminate the care. Because a patient wants to pay and is self-pay, that does not exempt them from any of the requirements for the 12 visits or 45 days. So don't confuse the payment side of it with what is allowed by law. So Medicare actually recognizes direct access. Medicare's requirement is that you don't need a referral to initiate care, but you do need to have a physician sign that plan of care within 30 days. Basically, what Medicare is requiring is that the patient be under the care of a physician. Now, just to let you know, that is a big area that APTA is working on to try to get CMS Medicare to remove the requirement that a plan of care needs to be signed. That would just be wonderful for us if that happened. But as of right now, they have to be under the care of a physician. So could you see a patient for 12 visits in 45 days under Medicare and then just discharge them? Legally, yes, but we can't bill Medicare because you don't have a signed plan of care. So if the patient's thinking that Medicare is going to pay and they don't have a physician and you're seeing them under direct access and they're under the impression Medicare is going to pay, but yet you don't have a physician to send the plan of care to, you're putting yourself and the company in a very liable position, very exposed position, because the patient is understanding that you're a Medicare provider and that they should be able to get covered by Medicare. And it's almost misleading. You say, oh yeah, legally I can go ahead and see you. Just make sure with Medicare that they do have a physician, and the recommendation there is you can evaluate the patient, set them up for your appointments, get the name of the doctor, and see if you can verify with that doctor that you can see the patient under a signed plan of care. They will sign it. That's why we put a hold after the first visit on the Medicare, because you don't have a physician. They don't have a physician. If they have a physician, you can put the physician's name in there, but understand that is a physician that will sign the plan of care. I run into this one so many times when I was practicing that you call a physician. And a lot of times, if you know the patient, you probably know the physician. You say, hey, Mrs. Jones came back to me for her reoccurrent IT band issue. And I just want to, can I go ahead and treat her? When you sign the plan of care, and if you get an okay from their office, then you're good to go. And you can list that physician as the referring physician. But I would never treat a Medicare patient that says that they don't really have a doctor following them for that issue. It puts you in a precarious position. So some takeaways from this, and then we'll open to questions. The decision to treat a patient as direct access is yours to make, and that pending financial considerations. If they have a diagnosis from a practitioner who's authorized to diagnose in California, they're not direct access, and payers establish their own rules. The patients need to be informed of their financial responsibility if you're treating them under direct access. It's best to always err on the side of caution in getting a referral. However, direct access is a great way to elevate the status of our profession by letting, especially patients that come into you that are kind of your patients, they're lifelong patients, to let them know they can just come to you when you have an injury directly. But with the understanding that the payer issues related to their coverage, they come to you directly. It's a great way to establish a relationship, to know that you can be a primary caregiver for their musculoskeletal condition. And that's kind of where we want to get professionally. So So a couple things also I want to point out here. So my conversations today with Jason Kaiser from the PT board, asked him specifically what's been occurring from an enforcement standpoint on direct access. And he said what I thought he was going to say. He says they have very, very few complaints of, he said he can hardly think of any, of where a patient has filed a complaint against a PT that they were harmed under direct access. He said, however, they have a lot of violations of the direct access rules, because if a patient complains about something else and the reviewer comes on site or looks at the medical records to review the case, and note that anytime there's a complaint against us as a licensed professional, the reviewer doesn't just look at that one complaint. They go in and take a look at other patients. They usually review up to 10 records to take a look at what is the general care that you provide in addition to the complaint. And if they see a pattern of violation in any area, it exposes you. And that's where they are finding that they are having violations, is that when they open up other records and they see that somebody's been treated for 12 visits or 45 days or longer than that, and there's absolutely no record of a signed plan of care or a diagnosis, that's when the violations and the citations go out. And also note that any time during those 12 visits or 45 days, the patient goes to the doctor and gets a diagnosis that comes back, they are no longer under direct access. But the direct access period goes away when they have that diagnosis. So what I want to do now is just open it up and see if I can answer some of the questions. And probably the best thing is either to raise your hand or speak up, and whatever you want to do.
Hey, Rick, it's Jason.
Jason, how are you?
Good. How are you? So I got a quick question, just scenario. So a patient comes in direct access prior to the 45 days or prior to the 12 visits being expired. We can have a plan of care faxed to the medical doctor, to maybe their family doctor or something. And if the MD is amenable to it, they can sign and send it back. And that will allow us to continue. As far as
technically it would. The law says that they have to have a video or face-to-face conference with the physician.
Okay.
But it's up to the physician if they want to sign that plan of care without that conference. And yes, if that plan of care comes back, they said, so in your plan of care here, so here's kind of a key missing point we didn't mention. So they don't have a diagnosis and they come in, but you're writing down you're actually giving them a functional diagnosis. Right. You're giving them a diagnosis that they're they have something that you're able to diagnose, which is a functional deficit. They have difficulty walking, they have balance disorder, they have soft tissue injury to the gastroc. You can write down those things, and if the doctor signs off on that, then they're confirming or verifying that your assessment is fine, and that counts as a diagnosis.
Okay.
So that's the way you can do it. Yes.
Okay. Because I see that, sometimes patients too, the direct access patients that come in, you tell them, okay, well, you're gonna need to stop care. You got to go in to see your medical doctor. If there's certain patients where their family doctor or their orthopedic doctor they've seen in the past may be amenable to just, signing a plan of care. Now, some MDs will, some MDs won't. Then I think that in that instance, that would work and be, more efficient as far as maintaining follow-up visits for patients. And I see a lot of drop-off in care in my clinics in the past if you have to make the patient go back to see the MD. And I understand certain circumstances you're going to have to, but if there are circumstances that lend themselves to where you could send the plan of care, and if the insurance company, is okay with direct access and not requiring an initial MD prescription, that's
fine.
Scenario 2, then it should be fine. Okay.
Yeah.
And then I had another question then too, in relation to, let's say a PPO patient comes in with a original prescription and they're approaching the end of that original prescription. Same deal. Can we send a plan of care to their referring MD to have that signed, sent back? That'll function as a prescription without them having to go back and see the medical doctor in clinic.
So the only reason you need that ongoing thing, ongoing referral prescription is for insurance, because if they came in with the original one,
then you're fine.
You should have the diagnosis on that.
Got it. Okay.
Already, so you're legal. So you're doing that because of insurance reasons. Yes.
Okay. Yeah. I just see from like a functional standpoint as far as patients and getting them in, as quickly as possible, and having a good continuum of care. I think that might be something that we can explore a little bit more in our clinics, instead of just having them stop and then tell them that they have to go back to the end.
Yeah, that's what we want to avoid. We want to avoid those breaks in care. And yeah. And also, allows you to establish a relationship with physicians that you might not otherwise have a relationship with, by communicating on the patient's condition and then in a better manner than just kind of just saying, go back and see the doctor and stop your care. That
exactly. Yeah.
That you kind of lost the opportunity to even interact with the physician.
Got it. Yeah. That's what I was thinking. Thanks, sir.
A very quick question. Yeah.
Sorry.
Hey, how are you? You may have covered it and we just missed it. Similar to Jason's question, when you look at scenario number 4 that you had popped up there, and as that relates to someone with Medicare, and let's say the patient with Medicare comes in and you saw them with a diagnosis, as they saw a physician, received a diagnosis, the frequency duration of that initial referral is now used. Does that patient with Medicare have to go? Do we need a prescription or another referral for Medicare after the initial duration has expired, and it's still medically necessary there's definitely medical necessity to keep treating?
Yeah, so Medicare, we only get paid when you have a signed plan of care for the period of time that you're treating the patient. So you always need in Medicare, you can establish your initial plan of care up to 90 days. A lot of us don't do that. Even so, let's say you get a referral from a doctor and has a frequency and duration on it. It's Medicare. You send out a plan of care to that physician that has to be signed, which is the only way we get paid by Medicare. That is a frequency and duration that's beyond what they put in the initial referral. So let's say they say 3 times a week for 4 weeks or twice a week for 6 weeks, and you put down 3 times a week for 90 days, and the doctor signs that usurps the original referral. So if at the end, so that now that you have 90 days with the patient, that's the legal limit that you can do in your initial evaluation of a Medicare patient. As far as getting paid, you can go up to 90 days. But let's say we still require just to clarify this even more, Medicare still requires a progress note be sent every 10 visits or 30 days. So they would still require that. In addition to the fact that your plan of care may be for 3 months, you still have to do the 10 visit or 30-day progress note. So in order to continue to see the patient beyond their original your original signed plan of care, you have to get another plan of care signed. And you're supposed to get it signed before the expiration of the original plan of care. So if you go 90 days, you should be getting that plan of care signed before that 90 days expires for the next period of time. Does that answer the question? Sort of answers the question.
It does. I mean, sending a plan of care and receiving the plan of care back, as we all know, are 2 different things.
Yeah, I know, and there's things we do internally. I don't want to speak out of turn in terms of our internal policies, but if you send plan of care to the doctor and they don't send it back, technically you can still treat the patient as long as you document that you have sent the plan of care and you made attempts at it and it's documented in the record. You can continue to see the patient.
That's good.
By law, you can do that. We may be stricter on internal policies because we want to make sure we have that signed plan of care. But if we don't have it, you document that you try to obtain it. When Medicare does audits, they look for kind of like patterns of that you automatically never extend your plan of cares and you keep seeing the patient. That's not good.
Rick, I have another question. This one question goes to Starla, and then I guess it's just the functionality of Raintree, and maybe I'm just not aware of it. But when we click to send the plan of care to the medical doctor, is there a line or some sort of verbiage that requests MD signature and lists the fax number for which the medical doctor's office should send back the signed plan of care?
Yeah, the last page of it has some verbiage in there about their signature, like approving the plan of care. If there's any PCC leads on the call, they can probably tell you exactly what it says.
Okay.
And then if it has our fax number, I'm not sure. I can send you a screenshot of exactly what it looks like though, Jason.
Okay, cool. Yeah, because I just want to make that effective communication to the MD office to get that, to get it sent back so that everything's there and it's like easily visible for them. If they don't see it, they just won't do it. That's what's
Sure. Yeah.
Thanks.
Yeah. It's at the bottom. If you click view document, it'll be right at the bottom to the instructions to fax and sign.
Thanks, Yadira.
Okay, thank you.
Hey, Rick, I think
Yo.
in the old days, there had to be something posted in the clinics, right, about direct access. Do we still have to have?
Yes, we do have that in our clinics. I'm pretty sure we have that. We should have it up in the front office of our clinics as far as it's not necessarily the direct access, it's that the complaint process that the patient can follow has to be posted.
And then and I think we had to have them sign a form that they were going to be seeing direct access.
Yes. So that was that like the second or third slide I had in there. You have to, the notice to the patient. We have that, and they should be, that has to be placed in the patient's record.
And then the $1 million question, can you see a direct access patient for a personal injury?
You tell me.
Yes, you can, but keep it short, because in the real world, at the end of the PI case, a lot of times they'll try to discount those visits. So do the best that you can. It's difficult. It's not easy, but that's where you can get help from the marketing team. See if the marketing team can get a prescription directly from the doctor. Be careful too, front offices. We don't want to bombard the doctors with many phone calls regarding the prescription or the attorney. That's why in some cases it's better to have the marketer go out or get it yourself. Swing by the office and try to get that.
Yeah, I mean, a PI case is somebody that needs care, so you can see them through direct access, but you know that patient's going to have to be under the care of a physician at some point. And I would even think that, if it's coming from an attorney, that attorney has relationships with physicians too, in case the patient hasn't, been referred to a physician yet. That might be another way. It's going to the marketing team or back to the attorney's office, say who is the, who the doctors you're working with that you would like this patient to follow this patient.
And then the last question I have, or I don't know, it's a statement, right? It's a rhetorical question. Can you have direct access and workers' compensation in California?
No.
No. Okay.
Well, I mean, you technically can see the patient's not going to be covered. A work comp injury requires a physician involvement, requires that when we got the direct access laws passed, it exempted work comp from it. It doesn't say it in the law, but it doesn't apply to the work comp situation.
Well, and then regardless, you need pre-authorization. So without
Exactly.
that,
You're not going to get it without a physician involved.
correct. Thank you.
Welcome.
All right, guys, it's almost 1 o'clock. So if anyone needs to hop off, I know you probably have patients at 1. By all means, if there's any other questions, I think we can probably stick around for another minute or so. Or any questions can always be emailed over to Rick as well. Not to volunteer you, Rick. But,
Yeah, no, feel free to shout out to me, email or phone call or whatever. There's always these questions that come up. Happy to answer them.
Good. And there's nothing in the chat, so I think we're all set. So thank you so much, Rick. We really appreciate it.
Thanks, everybody.
Thanks, Rick.
See you next
Thanks,
time.
Thanks, guys.
Yeah.